I don't think there's anyone living with obesity who's not heard eat less, move more. I think it's the surest way to sabotage your relationship with patients.
That's the voice of Dr. Robert Kushner, a passionate doctor, educator, researcher, and advocate for improving the lives of people living with overweight and obesity for more than 4 decades. And his compassion comes through so clearly in this conversation. He's joining me today to talk about his brand new book, Patient-Centered Weight Management, the Six-Factor Professional Program and Toolkit. Well, welcome back to the Exam Room Nutrition Podcast. I'm your host, Colleen Sloan. I'm a PA and dietitian, and before we get into this episode, I just gotta know, how you doing? This week has been really heavy. This week has also been really cold. So if you're carrying a heavy burden today, I actually just want to pause and let's all take a deep breath together. I'd also like to take a moment of silence and pay respect to Alex Preddy and honor his life. All right, thanks for doing that with me. And feel free to reach out if you need a friend. I'm on Instagram at Exam Room Nutrition, or you can always shoot me an email at colleen@examroomnutrition.com. Well, I often talk about GLP-1s on the podcast, and it seems like there's a new drug or approved indication every week. But the foundational principle is that lifestyle interventions still matter, and we still need to utilize them in clinic. Because we all know that obesity is a complex disease. There's numerous factors that drive it, and some of those factors cannot be addressed by pharmacotherapy alone. So when I heard about Dr. Kushner's new book, I couldn't wait to chat with him. So in this episode, you'll hear about why lifestyle counseling still matters and learn some new strategies for effective behavior change. And we dig into the concept in his book called the Six-Factor Questionnaire and how it's going to help you quickly identify what's actually driving a patient's struggle. Now, I love when smart people create systems that make our lives as clinicians easier and the advice we give better. Now, we barely scratched the surface of all the incredible resources inside his book, so the link to purchase it is down in the show notes. You're going to love this conversation if you're looking for a little bit more guidance and maybe like a framework for how to have these nutrition conversations with patients struggling with their weight. So get comfy or drive safe and enjoy my conversation with Dr. Kushner. Well, Dr. Kushner, I am so excited to have this conversation with you and to unpack your brand new book and some principles that we can all take away from that. So thank you so much for spending time with me today. Welcome to the show.
It's my pleasure. Thank you for having me on, Colleen.
Okay, you have a wonderful emphasis where the era of telling all patients to eat less and move more is over. And I believe all of my listeners will celebrate that because I very much agree with that. But I would love to hear what are some ways that generic advice that we've given maybe in the past have missed the mark?
Yeah, well, I do want to emphasize that I don't think there's anyone living with obesity who has seen a healthcare professional has not heard eat less, move more. I think it's the surest way to sabotage your relationship with patients is to say that one more time. I think you and I know patients want to be listened to. They want their stories told, they want to be acknowledged, and they want to be counseled on their perspectives and their goals and what their barriers are. So let me come up with 3 common examples, I think, where people trip up on generic advice. And the first one, which predominates, is making assumptions. Like, I want you to eat more fruits and vegetables when indeed they are. That's not their problem. Another one is just not being aware of what we call social drivers to health. So that you may say, I want you to eat healthy foods, but the patient lives in a food desert or has food insecurity. The other one is counsel more on physical activity, but you don't know they don't live in a safe environment. There's no sidewalks. They wouldn't walk in their area. So just asking a little bit more about their personal story can get around all of that kind of generic advice.
Now, you also mentioned personalized nutrition. So I would love to hear kind of your definition of what that is. And then why do you think personalized nutrition is important in today's day and age?
Well, I think most clinicians are pressed for time. And as I've already said, people want to be heard. They want to be acknowledged. So to give advice that doesn't resonate with them is just really not going to work. And that really gets to the whole idea of my program, which is phenotyping or segmenting the patient. I mean, what could be better than have a time efficient, time saving program that really identifies the patient's problems that they are presenting without just saying some general information. That really is the foundation of the Six-Factor program.
Great segue, because that's my question. I want to get into the Six-Factor Questionnaire that you've created. So explain to us what it is and how will it help us quickly identify what's driving our patients' challenges.
Yeah, well, the whole thing actually started, we'll talk about that maybe a little bit later. It really started by seeing all these patients and what could I come up with where I can quickly and efficiently and effectively find out what is going on with this particular patient. And that's what gave birth to the Six-Factor Questionnaire. So let me just walk you through the process quickly. The Six-Factor Questionnaire is a 27-item self-administered questionnaire that identifies what behavioral mindset factors are most important to focus on when you're counseling. Each item is answered using a 4-point Likert scale ranging from agree or don't agree at all, and we generate a score for each of those factors. It's funny, let me pause there. When patients fill it out and I go over with them, they go, "Doc, you got me. That's me." Of course, I remind them, well, you filled it out. Of course I got you. That speaks to the questionnaire really getting to the actual issues. The next step is to use what we know is shared decision-making, right, to select what changes the patient wants to focus on based on that factor score. And I just want to remind you that not only is the Six-Factor Questionnaire in the book, but also in the consumer book that I wrote preceding this called Six Factors to Fit Weight Loss That Works for You. So there's a commonality in these two books, consumer book and professional book.
I'm going to talk practically real quick for some of my clinicians. How do you incorporate this into a visit? Do you give it to them before the visit? Is it part of their pre-check-in paperwork, or are they filling it out while they're waiting for you? Kind of what does that look like in clinic?
Yeah, so in the clinic, there's many ways to do that. You can either send it to them in advance, which is what we do at Northwestern, because we could send it to them either by email or on a website, and that could be done before an in-person visit or a telehealth visit. If it's an in-person visit, it could be done in the waiting room or in the actual exam room itself. The key is to have that information completed before you see them. And the way the questionnaire is filled out, if someone is knowledgeable enough, they could actually score it themselves and come on in with it scored. And what you're going to then do is to interpret it to them and talk them through it, which is really part of the counseling process, actually.
Okay, it's music to my ears that you are talking all about like making the process quicker, making our visits more efficient, because I think that is really, really important in today's day and age of medicine. And so what does a clinician explain to the patient, and how long does that actually take?
Well, it does start off, like we just said, with them filling out the questionnaire. And then I go over it with them. Of course, I explain what the different factors are or phenotypes are. So they have to understand the definitions of what we're doing, which doesn't take long. And as we're going through that, we can then decide which ones do we actually want to focus on. So that's really what starts that counseling. And we do that, again, in a shared decision-making process. So we typically would start with the factor that has the highest ranking and it resonates with the patient. Let's say they are a easily enticed eater, the love of food. They have difficulty turning down food. We would start with that. Another way would be to start with a factor that has the greatest impact, which would be a diet factor, let's say, rather than something else. Or a mindset factor, like a fast pacer, like to say doc or a healthcare professional, PA, whatever whoever the counselor is. I understand this. I'm not a stupid person. I have a lot of motivation, but I am a fast pacer. I have so many things going on. I don't know where to start. So you would then pull up that information. So in that 15 minutes, the counseling begins with what's going on with them. So it resonates with them. And then you quickly tie that to here's what you can do leaving the office today. And the book and so forth come with handouts, camera-ready tips, worksheets, explanations of the factors and so forth. That's all downloadable, available for the provider.
This book is a plethora of information and tools providers can then give off to their patients. So it's amazing. Okay, we've teased it enough, and I really wanted to get into the different 6 phenotypes, or those types of patients that you had just mentioned. So walk us through those different types based on the scoring, and then what do they reveal about our patients' behavior and maybe their mindset?
Yeah, good question. So again, there's 6 factors. Right? I interchangeably use either segmentation or factors or phenotypes, is however you want to think about it. It's really identifying what the barriers are in that patient or what led to them being overweight. So the first 2 are diet-related factors. Called convenient diner, so someone who eats out convenient foods, fast foods, ultra-processed foods, or easily enticed eater. That's someone, the love of food and the enticement of food. So those are 2 diet-related factors. And you can have a little of each, but that's the dominant factors. There's one physical activity factor called exercise struggler. Someone who never enjoyed exercising, they're not physically active enough, too much sedentary time, they don't know how to start a resistance program and so forth. And then the 3 last ones are mindset factors. Fast pacer, doesn't have enough time in the day, busy taking children, carpooling, working, and so forth. Self-critic, someone who really has a low self-worth or low self-esteem, sees the negative in things, always has a but when you're making recommendations. And the last is all or nothing doer. We see this person all the time. It's the perfectionist. It's the one who, if I can't do it perfectly, I'm not going to start at all. Or I'm a weekend warrior, and then the week comes and I don't do anything. It's that all or nothing mindset. So those are the ones, this was done through a biostatistician and me at Northwestern. They all segregate differently. They don't overlap, but you certainly can have more than one factor. So when we're working with someone, we identify which one do you want to work on? And that's where we get started. Typically we're trained to do one behavior at a time. And we often do that, although someone says, I think I can easily get myself moving every day. Let's take on a second behavior so we can go ahead and do that as well.
I'm really glad you explained what happens if a patient is has scores high in 2 of the different types, because it sounded like that could have been complicated. But I love how you always go back to a shared decision approach, and it reminds me of a principle in motivational interviewing called ask, offer, ask. And it sounds like that. You can give them an example of, you are these 2 different phenotypes. Which would you like to work on, right? And it kind of takes the work and the digging off of our plate and it puts it onto the patient. Is that sort of your approach there?
Well, absolutely. Shared decision-making should be part of every session where counseling is involved, either changing a behavior, which is what 6 factors of fit is, or even screening or treatment decisions. We would never mandate or tell someone to do that. That's a early career mistake, is to start getting in that mode of, this is what I think you should do, the Mediterranean diet, or however we do that. It's all about shared decision-making. And that's the beauty of the 6-factor program, is that I have the wealth of information. I can share this with you. That's my role in shared decision-making. I can inform you of what are directions to go, tips, strategies, different maneuvers you can work on. But what I need to hear from you in that shared decision-making process is, what are your values? What do you want to work on? And then through that process, we move forward.
I love that. It's so great. I love that approach so much. Now, I also love the names of these different factors, and convenient diner or all or nothing. Those are so great. They're so relatable, and it makes me question, what is the role and the importance of self-identification? Because I'm sure, like you had said, the patient's like, doc, you get me. That is me. Why is that important in behavior change?
Well, let me say something about these names, because we learned something and this is published with my wife, by the way, she's my co-author and a nurse practitioner. We were made aware by one of the reviewers that says people don't want to be labeled. So you shouldn't call me a fast pacer. You're labeling me. It's like calling someone an obese patient. We don't do that. We use people first language now. So we talk about someone who has fast pacer tendencies. That's not how we're labeling them. But I think everyone loves to be identified. I mean, how many individuals will pick up a magazine or a digital article where it says, take this quiz to find out fill in the blank? Everybody loves doing, because they want to learn about themselves. So it's the same when we're in the clinic and we turn the screen to them and say, we tracked your diet over the past 5 years. Their eyes are glued on the screen usually, because they want to know about themselves. So it's just, people want personalized advice. They want to have something that's going to be geared to them, Again, recognizing you are speaking to them, their stories, their barriers, obstacles, and opportunities. So I think we need to do that across medical care, and particularly in obesity care.
Yeah, it sort of gamifies it too. Like, this is a fun questionnaire for them to fill out. So much of the medical paperwork, like the HIPAA, release form, it's also boring and sterile. Like, this one is actually really fun and gives them such an insight into their own behavior, their decisions that maybe they weren't aware of before. So I love it. Now, I want to do some practical teaching here. I would love if you can unpack maybe one of the factors. And if this was a patient and this was their dominant factor, what are the next steps that would guide the clinician's counseling approach to the treatment of that patient?
So let's take exercise struggler as an example. So, we often we assume individuals who come in with obesity are not physically active. And that's not necessarily true. But there are individuals who are more sedentary. They're not getting enough physical activity. So first, I would identify through the different items that they are with that factor. Using shared decision making, I say, does this make sense for you to work on this as our next factor? And you go, yes, I want to be more physically active. We would then use SMART goals: specific, measurable, actionable, realistic, timely. That's typically right out of behavioral change, in which we will come up with a very specific action plan for them to get more physically active. And it really built off their story. Are they commuting on the train? Do they have an opportunity to walk? Do they have time at lunchtime? Do they have a dog? It happens to be also overweight, so you could take your dog for a walk. Do you have a partner or significant other you could walk with? So you really come up with a very specific plan with goals. We often have them use wearables or their smartphone to track steps, or if it's resistance training, what that is like. Can you afford a personal trainer? Can you go on YouTube? So we have them leave the office with very specific plan in order to increase their physical activity. And we would use very similar types of strategies and techniques for the other types, but they're more geared to that particular segmentation.
And you really encourage just focusing on one thing at a time. Like, you're not going to focus on the exercise and the diet at the same time, or do you have patients who want to do that?
Well, you can. Someone could be ambitious. Sometimes we set up, we call stretch goals. So this is what I want you to work on. But if anyone has done any athletics, you know about stretch goals, like, beat that time or swim an extra lap or, do some more weights. So that's okay. We need to remember, and I tell my medical students this all the time, you have, let's say, 15 to 20 minutes, and some people have 45 minutes with a patient. That is such a small sliver of their life. They then go back in their community, their workplace, their home, and it's very difficult to change behavior. People in your household may not want to change this to the same direction that you are guiding them to do. So I always want to be modest, but you want to pick something that they're going to feel successful and they're seeing progress. Nothing is more motivating than success. So move that forward. And Colleen, I do want to mention one other thing, and it's the other value of using this questionnaire. Oftentimes, after 3, 6, or 9 months as a clinician, we'll say, what else are we going to work on? We've already gone over everything. What a wonderful time to give the questionnaire again. 2 reasons. One is they can see the progress because their scores are going to improve. And we use a bullet, a bullseye figure in the book and in the consumer book. So everything starts moving towards the center in the green, and they can see themselves getting better. But also for the clinician point of view, you can see what's improving and what's not improving. Sometimes someone may have an injury and they become a exercise struggler where they weren't before, or they became a fast pacer because they got a new job and a promotion. So it helps you to stay ahead of the curve on what is changing, and it gives the patient an understanding of how they've improved beyond the scale, really on their mindset and on their behaviors.
Yeah, what a helpful tool with such good data for us and the patient to evaluate and see how much progress they've made. I love that. Now, I'm curious how this would work, and especially digging into shared decision making for those patients who maybe are defensive or who come in and they are just defeated because they've, quote, tried all the diets and whatnot. What does it look like in that specific patient?
Well, again, with shared decision making, you shouldn't be going toe to toe. That's the essence of shared decision making is you're valuing each person's ideas and you come up with something. I turn to motivation interviewing. You mentioned it earlier in the podcast. there's one of the elements called roll with resistance. In other words, you should never go toe to toe with a patient. You should say, I acknowledge what you're telling me. It sounds like you are frustrated. I could understand you're frustrated, but here's another direction we can go. We have so many treatment modalities these days when it comes to obesity care. The richness of lifestyle management, which is what this book is quite a bit. We have these new highly effective pharmacologic agents that we can use if you're a prescriber, and even bariatric surgery. So there's so many things that we can do. It really begins with listening to the patient, but also escalating care or changing care when needed. The last thing we want to do as a provider is say, try harder. You did it before, do it again. We always want to understand what their situation is. And we never use the word excuses. We use explanation, and then we go from there.
Yeah. It's not our job to change anybody, right? We cannot do that. And I speak about that often on the podcast. If you guys have been listening for any time, I have several episodes all about behavior change and helping our patients. And it is often that mindset for us to have that, hey, that patient sitting in front of me, they aren't the failure. It was the plan that failed them. So let's just rotate and choose a new plan. Let's find a new strategy. So I really love how this book helps us do that.
Yeah. Let me just add, what you just said is so important, and we need to make that clear to our patients, because most of our patients, or a lot of our patients, do feel it's their fault. So we need to explicitly make it clear to them that it wasn't you. It is not your fault. It's the direction or the plan that we chose to go on. Let's shift gears.
Oh, empowering. And, just listening, if I were in the patient seat, I would probably feel tearful if a provider had looked me in the eye and said, like, it's not your fault. Like, you are not a failure. So you guys do this today with your next patient. Remind them that they are not the failure and you're there to support them and find a strategy that works. Okay, I know your book is mostly focused on lifestyle management, but I'm curious as to how anti-obesity medications fit in this six-factor model and if there's certain phenotypes that might benefit from these medications.
Yeah, that's a good question. So, lifestyle management is foundational. I mean, when I started my career 4 decades ago, that's all we had was lifestyle management. Now we have, all slew of other medications, but it remains foundational. So you could take medication, you get bariatric surgery. It still comes down to mindset and behaviors. If you're taking medication does not make you be more physically active. So that is, or sleep better, or deal with stress better, which are these foundations of lifestyle. However, the one factor that seems the most sensitive to the new medications is the easy enticed eater. And that's the whole idea of food noise and thinking where your next meal is going to come from. And I'm always hungry and I never feel full. And the medications really reduce food noise, as we all know. And food noise is part of that easy enticed factor that I see food, I smell food, I taste food. It's hard to walk past a desk without eating it. I just love food. I'm a foodie. These medications really help that particular factor. And that's the one that most exquisitely comes down, normalizes, if you will. The other ones may take a little bit more time. Some of them are not states, they're traits, meaning that's more of my personality. A good example would be the all or nothing doer. When I see someone who's an all or nothing doer, I always ask them, are you kind of a perfectionist just when it comes to your weight, or is that how you are in general as a person, is your worldview? If they go, it's kind of my worldview. If I take something on, I'm going to be the chairperson. I'm going to be one that's carpooling. I'm the one, the head of the PTA. I'm the one who's going to be, in my job, the one who's going to be the go-getter. That's a trait. So that's harder to tackle, but it may be what's getting them in trouble. Again, medication may not help that. I just wanted to mention the point about other factors.
Yeah, no, it's so interesting. I think that's really, really helpful. And I love your approach that sometimes, yes, medication may be the strategy that we need for this patient. However, lifestyle management tools are always, always, always part of your plan. You can talk about stress, sleep, nutrition, physical activity. All of that should be discussed with your patients, regardless if you're doing medication or not. Okay, so cognitive behavior strategies run through your program, and I love it. But I would love if you could share with us some techniques that we can use that would support behavior change with our patients.
Yeah, well, I'll tell you, CBT or cognitive behavioral therapy is the workhorse of obesity care. There's a whole chapter, as you know, because you have the book on behavior change. And it's probably the largest chapter in the book on behavior theories and principles because I think it's a science. And I think all of us would benefit from it. However, you do not need to go to school as a psychologist or a behavioral therapist to use some of the key components of cognitive behavioral therapy. And let me mention some of the ones that I use all the time, and I think one can handle in their practice as well. The first one is self-monitoring. Tons of data show if you self-monitor something, track something, you're more likely to be successful. So you can encourage your patients to track their diet. You don't have to do it, like continuously 100%, like if you don't do it, you're a failure. But even tracking now and then or a few days a week can be helpful. And that could be done on a smartphone or on a computer or even pen and paper. You could track your physical activity. How many steps do you get? And that could be done through a smartphone or a wearable or pedometer. Also, you can monitor your weight. And that's just a scale at home, either digital or just scale. If you do all three, periodically track your diet, your physical activity, and your weight, you have an electronic dashboard. You know who that's good for? People who love technology. When I mentioned that, you could see I'm all over it. How do I do it? Because it makes sense. They have ownership of what they're doing. So that's called self-monitoring. Another one I talk all about, in addition, is stimulus control. And just like it says, you don't want to be things that occur before behavior stimulated to do it. So an example would be if someone says, Doc, every night I wander in the kitchen and I see those brownies or I see the chocolate cake. And of course I say, what do you think about not having brownies and chocolate cake on the counter? Instead, how about some fruit on the counter or turn the lights off, don't go in the kitchen and so forth. So having control of your microenvironment, home environment is a good one. The other two that I would say would be stress management because that's common to so many of us. It's hard as a clinician to do stress management, but if you pick it up, you could talk about deep breathing, mini meditation, yoga, or refer to health psychologists. And the last one I want to mention, which is also cognitive behavioral therapy, is social support. We know that social isolation, being alone, not engaging with other people can lead to depression, can lead to overeating, can lead to self-doubt and so forth. Self-critic is one of the factors. So make sure they're engaged with family, friends, coworkers, community activities. You don't have to be a psychologist to make those recommendations.
Yeah, I love that part about community. And I think another great thing that community provides is that accountability. And I'm sure you know this even better than I, but there's plenty of studies that show if you decide to do a change and join a group or a group of people who are all kind of on board with the same thing, you are far more likely to stay committed and achieve your goal than if you were just to do it alone. So I love to know your idea on accountability and how important do you think that is?
Accountability is extremely important. You can be accountable to the clinician. That's, I think, one of the things that I actually offer, although I don't like to think of it that way, but it is. Patients will often say, I was so looking forward to coming back to see you so I could show you how well I've done. That's in a positive sense. However, other patients I have not seen for a few months because they were embarrassed. I didn't think I made them feel that way, but they were embarrassed or ashamed to come back because they knew there would be some accountability and they didn't want to face that. And there I reassure them, I am not judging you. I am here to help you. But you also could be accountable to a significant other, and that's really well demonstrated in the literature as well. Have a buddy. Not someone who's going to look down on you and so on, but if you're accountable to others around you who you trust, who love you and so on, that could be helpful. Exercise is a good example. If you buddy up with someone for daily walks, particularly when the nice is out, or to exercise, you're more likely to follow through with it than if you don't have accountability to anybody else.
Yeah. I just want to pause and say that your patients are so blessed to have you because I love your approach and it should be all of our goals to have our patients kind of want to come back to us and share their successes, but also feel safe enough to come back to us if they have quote failed or feel like they have failed. Because I love that you just say that up front. I am not here to judge you. And I just am so grateful for your work in this field and the example that you are to
Well,
all of us.
that's very kind of you to say. This whole idea of a non-judgment zone is critical for anyone working in the obesity field, whether you explicitly say it to patient or you show it in your verbal and nonverbal, behavior.
And I think it's important at any age. I think a lot of adults, when they look back on, if they've got any body image issues, they can pinpoint it to like third grade, right? Like 8-year-olds are very aware of their body size and the things that we say to them or about them when it comes to their body. So I think it's really important. Doesn't matter what specialty you're in, but to always be very compassionate and aware of the language that you
Yeah,
use.
very much so. I always say words matter, and you don't mean it. But and I use the example of people first language before. An example, you're taking history. You say, is anyone else in your family obese? That's like nails on a chalkboard to some people. Versus anyone else in your family struggle with their weight. We both know what we're talking about, and it's just
Mhm.
an example of words matter.
Yeah. We could do a whole episode on
Yeah,
like
yeah.
say this, not that kind of words and phrases. Okay, but I wanted to end with a tricky type of patient, and it's the ones who are, quote, non-compliant. And I actually hate that word. I think it's one of those harmful verbiages that we've been just kind of been trained to use. And I think we should be untrained to use something else. And so how does the six-factor approach help reframe the thinking of non-compliance and then reduce our frustration with that patient and the patient's own frustration as well?
Yeah, I just want to double down on what you said about non-compliant. There's actually an ICD-9 code for non-compliance. I found it unbelievable. There is. Non-compliance is something we should never use it. It connotes bad patient, lack of motivation. You're not listening to me, right? The word is adherent. If you want to talk in that language, it's kind of get words matter. The six-factor approach is deeply rooted in personalized care where the patient is at the center. So it's not me telling them what to do. It's not a paternalistic or maternalistic situation. We've talked about shared decision-making from the very beginning. So you never want to get in the idea that I told you what to do, why are you not doing it? It could be very frustrated for the patient and the clinician. We have to remind, using motivation interviewing again, you don't want to go toe to toe. It's not a matter of frustration. You want to acknowledge frustration, but you don't want to say, why aren't you doing it? And we talked a little bit earlier about retaking the six-factor questionnaire. And that's something I would recommend because it diffuses the situation and say, you know what? Let's take just a few minutes. I'd like you to fill it out again because more often than not, there's changes in the scores that they may not be aware of. So it kind of diffuses some of that frustration. And you can highlight, you see, you did get better on a convenient diner. You're cooking more at home. You're preparing more food. You're reading labels, menus, and so on. You're doing a better job or reducing, sugar, fat, and salt, and so forth. This one, maybe not so. So let's change gears and look there. So there's ways you can get around this terrible concept of non-compliant.
Yeah, I love that. And it's a wonderful place to end. And we have barely scratched the surface to the content within your book. It's an incredible resource for clinicians. I will link down to it below. But Dr. Kushner, if clinicians want to follow you and just learn more from you and purchase your book, where would we send
Yeah.
them?
Well, it's patient-centered weight management, the Six-Factor Professional Program and Toolkit. Again, it's the companion to Six Factors Fit. You can get it on Amazon.com or go to the Academy of Nutrition Dietetics. That's the publisher to actually get both of them. And if you're a registered dietitian, I think you even may get it a little cheaper. To know about the book and me and all my activities, you go to www.drkushner, it's DR, or drrobertkushner.com.
Awesome. Okay, one last question. What do you hope clinicians get out of your book? What was your big overarching goal in writing this book?
Clinicians are typically not prepared and don't have enough education to tackle obesity. There are not enough obesity specialists to address the obesity epidemic. My goal was to develop a time-saving, efficient method to quickly identify what are the issues of the patients sitting in front of you that I can quickly identify and turn that around with tangible advice that will be helpful for them. So when they leave the office in 15 or 20 minutes, they say, you know what? That was an incredibly helpful visit and I have a direction to go right now.
Well, you have done that goal and more within this book. You guys, you go and purchase this book immediately after this episode ends. You will not regret it. You will learn so much. And there's so many helpful tools and strategies in there for you all. So, Dr. Kushner, thank you for the gift that you've given the obesity world and just for spending time with me on the podcast today.
Thank you, Colleen. That was very generous of you. Very kind. Appreciate it.
All right, now it's time for my nutrition notes. Now, there are two things from this conversation with Dr. Kushner that I really want you to remember. The first one, let's please all retire the phrase eat less, move more, and let's replace it with curiosity. Tell me your story first. Dr. Kushner was really blunt about this in the beginning. Saying eat less, move more, or a variation of that generic advice is one of the fastest ways to sabotage your relationship with your patient. Not because nutrition and movement don't matter. They obviously do. That's what my entire podcast is about. But because generic advice misses the actual barrier the patient is struggling with. Now, he gave 3 ways generic advice isn't helpful. First of all, when we give advice like that, we're making assumptions, like telling a patient to eat more fruits and vegetables when they actually are eating plenty of fruits and vegetables. When we give generic advice, we're also ignoring social drivers to health. Things like food insecurity, food deserts, and limited access are real barriers that our patients are struggling with. And unintentionally, we may prescribe activity without knowing the patient's environment. Maybe there's no sidewalk in their neighborhood, or it's an unsafe neighborhood. So before going into advice mode, go into detective mode first and ask about the patient's story. Ask them, what have you already tried? Or what's getting in the way lately? Maybe even just what's a typical day of meals look like for you? And I love this question. Is there anything about your budget, schedule, or access to food that I should know about before we try and make a plan? I promise you that 1 minute of context will save you 10 minutes of advice the patient can't use. All right, the second thing I want you to remember is that when your advice isn't working, it's usually because we're pulling the wrong lever. It's not that your patient is non-compliant. Dr. Kushner's 6-factor framework helps us stop guessing why a plan isn't sticking and instead identifies what's actually driving the struggle. Here's a quick recap of the 6 factors we discussed, and the book goes into them in even more detail. Number 1 is a convenient diner. This person relies on fast food, takeout, and chooses food based on convenience rather than its healthfulness. Number 2 is an easily enticed eater. They have a very strong pull toward food. They have a difficulty turning down food. This is what patients often describe as food noise, and GLP-1 receptor agonists can be massively helpful for these patients. Number 3 is an exercise struggler. These patients are more sedentary. Maybe they've never enjoyed exercise, and they kind of don't really know how to start. Number 4 is a fast pacer. These patients are chronically busy. They have limited time. They feel super overwhelmed and sometimes have a hard time prioritizing everything. Number 5 is self-critic. These patients engage in negative self-talk. They have low confidence, and often their worth is measured by the number on the scale. And lastly is an all or nothing doer. These are the perfectionist mindset, extremes of I'm all in or not at all. Now, Dr. Kushner reminded us that most patients don't need more education. They often don't need another handout of eat this, not that. What they need help is identifying which lever to pull first. Whether it's their food, environment, time, movement, mindset, or self-talk. Or maybe you need to help them see where they can pivot so they can actually start seeing change. When a patient feels understood, not judged, they are far more likely to come back, stay engaged, and try again. And that is the whole goal of caring for patients struggling with obesity. Now, don't forget to check the show notes to get a copy of his book. It's also where you can sign up for my free newsletter for weekly nutrition tips. All right, well, thank you so much for carving out some time today for nutrition, and I will see you next week. But until then, let's continue to help our patients be healthier, one exam room at a time.